And so if you have a mic and you want to ask a question, just know that it is going to be recorded, and I'll do my best to answer your question. If you're on a computer that does not have a microphone, feel free to use the chat feature on the lower right-hand corner and type in your question, and then I'll read your question out loud and then answer it. Okay, so let me hold on just a second. There's just one more person here coming in. It looks like it says, looks like Jason just logged in. That's great. Um, okay, Jason, you haven't missed anything if you can hear me yet, and we're just getting started now. So today we're going to talk about the topics that we went through on the first session, but in a little bit more detail. And I thought it would be good to start off kind of with our goal, which is to change the way people think about bruxism. And a lot of people are talking about sleep apnea. There's a lot of activity in that area, and it's it's an area that we know quite a bit about. But in the dentistry, dentists like to do dentistry things. So we believe that because there is a relationship between sleep apnea and bruxism, it's better to talk about the bruxism component first, and then we'll work our way into the sleep apnea component when that is a part of bruxism. So in achieving that, there's going to be we're going to move the market a little bit, and there's going to be a paradigm shift. And that is in the form of when you are assessing a patient with damaged teeth, what's the first thing that a dentist thinks about? And right now, typically they're taught certain things in dental school. And what we have learned from our experience collecting more bruxism and sleep apnea data combined than anybody else, we know that many, many times they're related. So when a dentist looks into a patient's mouth, they ought to be thinking, and they see damaged teeth, or the patient's complaining of TMD symptoms, uh, their jaw aches, jaw pain, clicking, things of that nature, they ought to think, okay, there's the possibility that this patient has sleep apnea. Okay, and if that is indeed the case, and we determine that's the case, the clinician or the dentist's job gets so much easier because you're essentially dealing with the elephant in the room rather than trying to work around it, which is a lot of times what ends up happening. So the paradigm shift is we have a report that quantifies clenching and grinding. Okay, and then we can also tell you how much energy is involved. So if of the clenching and grinding that we see, is it very destructive in just a few of them, or is it a lot of clenching and grinding but very weak, so there's not a lot of damage, or somewhere in between? So we have that capability, and we'll talk about the specifics of that next. And we're the only company that has a biocalibration for bruxism. And we'll talk about that and why that's important and unique, and why that is important for the patient to understand the strength of the clenching, because that kind of guides the acceleration of tooth destruction. So in other words, if there's a very strong clenching, tooth destruction is going to come more quickly, that type of thing. We're going to be able to talk about the participation of the airway in triggering bruxism. So we'll talk about how the two interact, and why we care so much about the airway, and why we take the airway into account when managing damaged teeth. And then we're going to talk about our BRX Pro, which is a unique tool that enables the dentist to not only protect the teeth but take into account the airway when indicated. So to kind of summarize this, we're going to triage the problem, and that includes snoring, sleep apnea, bruxism, and all how they work, how they work together. We're going to talk about kind of an unseen, huge benefit, which is warranty work. And the if you think about, let's say, a root canal, or you think about implants. And, a lot of times the reason you're doing an implant is because the patient's destroyed their teeth. And along the path of destruction, you pull the teeth and put an implant in. Well, then if they're still bruxing because they still have untreated sleep apnea, how well do you think the implant is going to go? Well, we don't know. If they do a really good job, it might go great, but it might not. And can you think of a bigger hassle than trying to redo an implant? I mean, just think about that for a second. And then we're also going to talk about how the dentist can actually improve the financial status of his practice, and how everything that we're talking about can actually be a financial opportunity. So that's what we're going to finish up with. Okay. Um, all right. Okay, I was just checking for questions. Okay, the non-medical report, or the DDME report. We do want to spend some time on that and spend a little bit of time explaining why this is unique. Okay, and the reason that this is unique is that I mentioned briefly that there's a lot of articles and publications on sleep apnea and dentistry and so on and so forth. It's the most talked about topic, but the least amount of practiced going on. So there's just not a real high adoption rate for sleep apnea. So we looked at why that was, and we addressed those issues with this report. Okay, and this process. So essentially we have a number of items on this report that are very similar to an item that you would see on a medical report, but it's not a medical report, it's a dental report. So for example, we have estimated AHI. So in this case, there's that number 19, and we'll talk about what that number means in a little bit. But when you're talking about somebody with damaged teeth, that 19 becomes very important. Now, we're not going to take on sleep apnea, but we need to know that that's a player in treating bruxism. And we do know that 19 is a significant number, and the dentist can now take that into account when he's deciding what to do. So that's kind of the first 8 boxes there are items that that anybody, we believe anybody would want to know if you're going to help a patient with damaged teeth. And we'll talk about the definitions of those. But at the end of the day, when you look at this report, you're going to know, as a dentist, okay, is the airway a problem? Yes or no? Do they snore? Yes or no? 22% of the time this patient snores. Okay. The BEI and the BBI, there's 2 boxes there. Those, what those stand for, BEI stands for Bruxism Episode Index. And that's how many times per hour does the patient clench or grind. 9.7 is a very high number, very high. It's more than double what's considered abnormal. BBI, about the same. It's just over double what's considered abnormal. And so when you look at this report, you immediately know that I'm dealing with a very severe bruxer, but they have sleep apnea. So I need to let's make sure that whatever I do, I take into account the airway. Because if you just do a guard, that AHI, that 19, there's a good chance that goes up and not down. Okay, so that's why this report's important. A couple other elements to the report that we offer is we give you an idea of how much energy is being expended. So the frequency was very high, but looking at this report, I can tell you that the strength is very weak. Okay, so there's some good things about that, some bad things, but it's a different approach. So I wouldn't be surprised to learn, if I were asked a dentist, that there was very little or maybe perhaps even no damage to this patient's teeth, because although their jaw fires a lot, it's not real strong. Okay, and you can tell that just by the total amount of energy that was expended, and the graphs kind of show that. And so at the end of the day, I say, okay, listen, let's see what we can do about somebody who fires a lot but not very strong. Okay, so we have this report that gives a lot of detailed information about the context in which bruxism occurs. Airway, snoring, are they a factor, yes or no? And then if they are, when the jaw fires, how strong is it? And a lot of people have wondered, how is it that we can kind of calculate how much total energy is expended? And what we do, and this is kind of, I mentioned in our first session that a lot of us, in fact, I think all of us at DDME have a medical background. And when you're doing medical testing, One of the things that is very common is to do a biocalibration. That is just whatever it is you're measuring, you have them do it kind of, and then you measure whatever it is, and you say, okay, this is the normal range, and then now go into a condition, in our case, asleep, and we'll measure the same thing. So we just took that very common, simple practice, and we put it into play here. So there's a calibration that we tell our patients to do. And essentially we ask the patient, bite down as hard as you can 5 times in a row. Okay? So then the waveforms on the screen, you see the little image there. That's what those waveforms look like. Those are clenches that the patient did as a calibration. And what we're doing is we're going to measure those and average them. So on average, when the patient's awake and you ask them to bite down as hard as they can, it's X. And then we have that, we save it, and we remember it. So when the patient goes to sleep, we'll measure the bruxism against X, whatever that number is. And then we can say, okay, when you go to, if you remember you did those cals, your number was 75, for example. When you go to sleep, your average clench is 120. And that's not unusual. So then the patient gets a sense that, geez, wait a minute, you mean I clench harder when I sleep than when I'm awake? And the answer is not only yes, but a lot. So that's how we figure out the total clench energy. So just to recap the report, we have basic numbers that describe in general terms the airway, snoring, and clenching and grinding. There's the clenches, there's the grinding, the number per hour there on the chart. It might be hard to see, but it's there. Then we give you some pictures to illustrate the overall energy compared to the calibration. And in this case, there wasn't a lot of energy expended, even though it was frequent. And then we talked about the cal. And so at the end of that, what you're going to get from us when you order a dental report is some recommendations. Okay. Again, at no point have we asked the dentist to send anything to a physician, because we're not taking on sleep apnea. We're taking on bruxism, which is a dental problem. So we're going to give the dentist some advice, and that's included in the report. So we give some recommendations, and based on our experience in the numbers that we see, we have we have templates. I'll just tell you, we have probably 25 sentences, and based on the numbers that we see, we'll kind of input the sentence, and then that report gets sent off to the dentist, and the dentist can then decide what's the best thing for the patient to do. Okay, so that's the dental path. And you'll notice I never talked about sleep apnea, in any real sense. I never talked about a physician read, because that's not what we're doing here. This is just for dentists that want to do a good job managing bruxism, and we believe in order to do that, you take into account the airway. Okay, now there's still the elephant in the room. Okay, in those cases where the dentist who's just going to do the dental part of things learns that the patient's at risk for sleep apnea, like that AHI of 19, or in the case of this letter, it's 18. So the dentist needs to deal with that. Now, they don't have to personally deal with it, but now they have information that needs to be dealt with. So in our software, we have a referral letter, and that letter, there's 2 copies of this letter. And the letter does essentially 2 things. One, it reiterates to the dentist and to the patient, okay, in the course of protecting your teeth, we learn that you're at risk for sleep apnea. We believe you should make an appointment with a sleep lab or a pulmonologist immediately. And here's the letter, and here's a report as to why we believe what we believe. And that goes to the patient. The patient signs it, and a copy goes into the dentist's chart, and a copy goes with the patient. And moreover, once we are working with the dentist for a while, we'll actually pick the sleep lab or the physician that we want to send that patient to, because then that becomes an opportunity to interact with the community. Okay, so the referral letter is meant to manage information we've learned and when we've assessed the patient for bruxism and learn that they're at risk for sleep apnea. The other thing it does, and it's unfortunate in this day and age, but we do live in a society that has attorneys, and we just need to make sure we do everything we can that the dentist is protected against anything that could happen. And so this letter is about as good of a step as you could take in that effort. So that's the other function that this letter serves. Okay? Um, all right, so I am going to take a pause here, and I wanted to see if there's any questions that anybody has before we move on to the next topic or not. So, and I know, so I'll kind of pause here for a second. I can in just a second. I'm kind of jumping ahead on my slides here. There we go. Okay, so we're going to talk about sleep apnea now. Oh, before I do that, because the answer to your question is like 10 minutes. So were there any other questions before I get into the AHI? Okay. So and again, if you don't have a mic, but you can hear me okay, if you want a question, ask a question. Just I'll be checking the chat box here from time to time. Actually, let me just check and make sure I'm not missing anything. Let's see here. Okay, no, okay. Looks like there's just some technical things there. All right. Okay, so now let's talk about sleep apnea. And I wanted to have a conversation about the basics of sleep apnea, what some of the terms and terminologies are, because it's one of those fields where it's almost like the military. There's an abbreviation for everything, and if you don't know what they are, you can quickly get lost in a conversation. So we're going to talk about some of the abbreviations and what they are, what they mean, and how they kind of fit into the scope of what we're talking about today. So sleep apnea, it's a partial or complete a blockage of the airway while a patient sleeps. And there's a number of locations where an apnea can occur, and there's a number of types of apneas that can occur. There's a type of apnea that we're going to talk about at the end. It's actually not an obstruction in the upper airway, but it's actually a neurological issue. Okay, so the sleep apnea, the main kind, when people talk about sleep apnea, the most commonly thought of type of apnea is where when you're awake, you breathe fine, and then when you go to sleep, you snore, and then maybe there's little pauses in your breathing, and there's a bunch of physiological responses to that activity. So, and those are the types of things that people talk about, those responses to these pauses in breathing, and we're going to talk about that. So, an obstructive apnea is when you have an event when you have your breathing, and it's the bottom box, and you'll see that there's that orange little rectangle there. That little squiggly line that then goes flat, that's the cannula. We talked about it briefly. It's a little nose piece that measures flow. When your airway gets blocked somewhere in the airway, that line goes flat because no air can get in and out. Okay? So what happens is essentially you're holding your breath. Okay, and a number of things happen. When you hold your breath, you pretty soon you stop trying to breathe a little bit, and then your body says, "Oh, wait a minute, I got to try to breathe harder." And then there's a big effort to kind of pop open the airway. Then the airway blows open, and then there's a big gasp. And in the course of you holding your breath, your blood oxygen level goes down. Your heart rate goes down, actually, which is counterintuitive. And then when your airway pops open, your heart rate goes way up and your blood oxygen level gets restored to normal. Okay? That could happen hundreds of times a night. Okay? So imagine holding your breath, your blood oxygen goes down, your heart starts to slow down because there's no oxygen to feed it, and then your brain kind of starts to respond, and it changes and puts an effort into getting your air back. Okay, now what happens is everything goes back to normal, and you go in and out of these apnea events, perhaps hundreds of times a night. The AHI stands for apnea hypopnea index. How many times do you have one of these events per hour? That's what the AHI means. So that person where we saw, if you remember, that number was 19 times per hour they had one of these events. Could have been an apnea, could have been a hypopnea. It doesn't matter. At the end of the day, when you're thinking about an AHI, we count them, divide it by the number of hours of sleep, and that's your AHI. Okay? So if you can imagine, just kind of pause for a second and think, okay, I'm going to hold my breath until my oxygen level goes down 5%, 20 times an hour. Now, that almost sounds comical, thinking about doing that while you're awake, right? So who would do that? That's crazy. One, most of us couldn't do it because we couldn't hold our breath to desat for the oxygen to go down 5%. But if you could, and then turn around and do it over again, and do it 20 times an hour, 6 or 7 hours a night. So that's why sleep apnea is so severe and so serious. You couldn't imagine doing it during the day. You couldn't function if you were doing that during the day. So the AHI at the bottom of the screen here, it says the AHI diagnosis scale. So 0 to 5 times per hour is considered normal. We all do it a little bit. And when you do it from 5 to 15 times per hour, that's considered mild. So, and again, it's some amount of closing of the airway or partial closing of the airway. Your oxygen goes down a little bit, and then your airway opens, and then your oxygen goes back up again. And then anything above 30 per hour is considered severe. Okay? Now, one of the nice things about the scale is it breaks out what therapy is appropriate. So up until about 3 or 4 years ago, everybody got CPAP. And then if they weren't successful on CPAP, plan B was an oral appliance. Most of us have probably heard that oral CPAP, one of the challenges of CPAP, as good as CPAP works, is people just generally don't wear them at a high percentage of the time. And the percentage of time, depending on who you ask, if you're a sales rep selling CPAPs, 85% of the people use it. In reality, it's probably 60 or 70% of the people who get a CPAP unit use it. So there's that 30 or 40% that don't. And, 4 or 5 years ago, that 30 or 40 were considered candidates for an oral appliance. Today, it's different. For the reason that oral appliances are people are much more compliant using oral appliances, meaning the adoption rate is much higher. So it's 70 or 80%. Some people are even saying higher. The downside to oral appliances is the worse your apnea is, the less effective it appears that oral appliances are. So the folks at the severe range, they're still not accepted as an oral appliance as the first line of defense for somebody that's severe. For mild to moderate sleep apneas, it is absolutely appropriate with nothing else to take into account except for the AHI. You got a healthy patient who has apnea. Any physician is comfortable recommending an oral appliance for sleep apnea. First plan A, oral appliance. And for those that are severe, they get CPAP no matter what. And if they fail on CPAP, then they can try an oral appliance. So AHI, number of times per hour you have a respiratory event. The A is apnea, the H is hypopneas. I really didn't talk about hypopneas, but I'll show you one in a second. And we just add those up times per hour, and that's what the AHI is. Okay. Now, there are some types of apneas that are not the oral appliance will not help, and that's central sleep apnea and Cheyne-Stokes respirations, number 3 and 4 on the chart there towards the top. Those two types of apneas are considered a different type of disorder altogether. It's not a dysfunction of the airway at all. In the case of number 3, central apnea is more of considered a neurological issue than an airway issue. And that is to say, central apnea means you don't have a drive to breathe. You just lay there. And the muscles that push the air in and out of the airway aren't being told to push. So you just lay there. And then, Because you're not trying to breathe. There's no, the pump turned off, and there's nothing going on. And then at some point the air, then that signal is going to change and you'll breathe again. So it's not easy to understand why an oral appliance would do nothing for central apnea, a true central apnea. I will tell you that number 3 is a very rare condition. It's something that it's I'll just leave it at that. It's rare. And so most people don't run across it. One of the nice things about the unit that we sell, it's one of the few units that can actually diagnose that condition. So, as a salesperson or a person that has some responsibility in sales, if you're talking to a dentist, and let's say that the dentist is looking at a competitor's unit that can't distinguish central apnea or not, yes or no, and our unit, how valuable would it be to that dentist to say, listen, you really do need to know if the type of apnea that patient has is going to respond to an oral appliance. Okay? Our unit can tell that. A lot of units can't. Okay? So it's a big selling point. In fact, it's why it doesn't get talked a lot, because a lot of the topics that dentists talk about are things that vendors bring up. And vendors know of other inferior diagnostic products that's an Achilles heel if they can't tell if the patient has central sleep apnea. Number 4, Cheyne-Stokes respiration. It's an indication of a medical problem, congestive heart failure, and we've gotten many dentists in the hero seat because we saw that condition and we called the dentist and said, hey, listen, that patient needs to be seen by a cardiologist. They have this breathing pattern, and it's a feature that we have at DDME, and we catch it quite a bit. A lot of people have congestive heart failure these days, unfortunately. So number 3 and 4, they're not obstructive sleep apnea events, but we can measure them, and there's some upside to the fact that we can catch them and help the dentist. Essentially, if the patient has that and you put an appliance in, everybody's time's being wasted. Okay? I'm going to take a pause here for a second. Does anybody have any questions on AHI and sleep apnea? Oh, sure. Uh, I will tell you that. That's a great question. So give me just a quick second, and I'll actually show it to you. And let's see here. Here we go. I'm pulling up a picture. So, I just speak better with pictures. Okay, here we go. All right. So coming up on your screen here in a second should be a very Nordic-looking gentleman, and he's wearing the monitor and those 2 white belts. You guys see that? And the 2 white belts, the top one, the upper one that's around his chest, that measures what we call the accessory muscles, the kind of muscles around the rib cage. And the lower belt that's around the stomach or at the navel level, that measures essentially the diaphragm. And it's the diaphragm and the accessory muscles that your breathing pump. And we measure the breathing pump with great accuracy, tremendous accuracy. And as a result, we can tell those 2 conditions. And moreover, we measure it so accurately. I'll show you something. The picture should be coming back. There's a channel here. It might be hard to see. Let me kind of make this a little bit bigger. I'm going to make the screen a little bit bigger. Okay. There's an extra channel here that, because we can measure the breathing compartment so well, it's a backup flow signal, because we know the volume of air going in and out of the breathing compartment. So, great question. And if you can answer that, so a dentist will say, why do I have to bother with those 2 straps when there's this other one I just put on the forehead? Well, the one that you put on your forehead can't tell you this information. And as a dentist, shouldn't you know if the appliance you're thinking about using is going to have even a chance of working? And the obvious question is yes, you should know. And so this is one of the reasons we like the unit. And if you're up against a competitor and they say, well, that one you just you wear a hat, there's some upside. It's simple, but you're not going to get critical information that you really need. Okay. Okay, that is I've heard a lot about that, and we have an oximeter too. And oximetry is required in order to diagnose sleep apnea. And there's a variety of types of oximeters, and there's a variety of analyses that can get run on the oximeter channel, but it is one parameter of 5 that you need. So even if it's the best one, it's still one of 5. So the important distinction between our monitor and the high resolution oximeter is that you get the one channel, fantastic analysis of the one channel, but it is the one channel. And you can't diagnose sleep apnea with it. You can't really get an idea of what's going on with the respiratory effort with it. And you certainly don't know what the snoring is doing. And so as good an oximeter as that is, and I agree, it's a great oximeter, it is just an oximeter. So that's what, if we're up against that, is it good when you're wanting to measure blood oxygen level? There's probably the best on the market for that. But when we're talking about sleep apnea and bruxism, we need more data. It's just as a matter of fact, and I don't think I'm going too far out of bounds by saying that there's a number of people that are very supportive of that oximeter that are evaluating our monitor as we speak. And so at the end of the day, when I'm talking to somebody who has one of those oximeters, they all know it's a great oximeter, but it's just an oximeter. And it's as good as it is, they really do need other info. Does that answer your question? Yeah. What we can do is we can talk about how oximetry is used in the context of our system. Okay, so and the key opinion leaders that I'm working with, that they actually like the high resolution oximeter, and then the sleep tracker that does cardiac coupling. And they use those two that are separate and different, and kind of try to get a full picture. We, you know, uh, they are great instruments, but they're not the whole picture. So I'll tell you why it is, and this is a great line of questioning, why it is what we do is so brilliant, and all the effort that other folks are doing, they don't really have to go to all these extraordinary efforts. The answers, we have all the answers. You don't have to, they're making it more difficult than it is. And that'll become clear when I explain how we use oximetry, how we use cardiac data in our system. Okay? And I'll make a point of explaining, okay, here's the type of oximetry data, or here's the cardiac data, when we're going through actually the next few slides. Okay? All right. So now what we're doing is we're looking at a sleep apnea event, okay? And what I want to do is I want to kind of go through a little bit with you, just kind of, to further answer the question, what is it that you're looking at? Now, don't feel you need to learn any of this, because, a lot of times when I show slides of raw data, and this is considered raw data, a lot of people say, a lot of dentists say, I just need to know the minimum amount to trigger a billable event. I don't really need to. Your job is to tell me what this is. I don't want to know it. But for the purpose of understanding what we do, I am going to spend a little bit of time in raw data, but not a lot. And if you're feeling overwhelmed, don't worry about it. If you want to learn more, call me. If you don't, it's not required for you to learn it. Okay? Okay. So what you're looking at is an obstructive apnea, not unlike the one I showed you a second ago, where the person's breathing, and this top squiggly line here is a person that's breathing, and then the airway closes, and you can see it goes flat. All right. Now the green line here, so right here, I wish I had a pointer. I wonder if I have a pointer. Screen. Shoot. Okay. So the green line here is the blood oxygen level. So this is the oximetry. So right now it's kind of hard to tell, but I can tell you it's starting at 92 and it goes down to 79. So this patient's oxygen level is at 92 and it goes down to below 80. Okay. So that's a very severe desaturation. And if you ever have the chance to wear one of our oximeters on your wrist, I'll ask every one of you, put your finger in there and hold your breath as long as you can. And you'll start at 95 and see if you could even get to 90. Most of you won't be able to. It's very rare that a person could hold their breath and lose 5% of oxygen. Okay? This person in this one event went down from 92 to 15. Triple what they could do while they were awake. Okay? So then the body goes into this mode. And you can see here below the green line is the heart rate, okay? And the heart rate stays pretty steady. It kind of goes down actually a little bit, and then it goes up, okay? So the oxygen goes down, the heart rate goes up, and then there's these two big giant black charcoal looking events. And guess what those are? That's the masseter muscle, okay? This is a Brux. So this is a person that has a sleep apnea, and in a desperate effort to pop that airway open, the brain says, I'm going to clench. Maybe that'll get me breathing again. And they did this big, huge clench. So this is how, in the cases where sleep apnea and bruxism are related, this is how it works. Okay? There's a number of things. So again, the heart rate goes down, the heart rate goes up, the SaO2 goes down, and then you see this big kind of messy event at the end, and that's the body trying to pop the airway open. Some of these other channels, like the channel here where it says RIP phase, second from the bottom, what's happening there is the airway closes, and right when the airway, you notice when the airway closes, this goes up. This is the body trying to pump. And the opening is closed, so it's pump and pump and pump. Nothing's happening, and once the airway pops open, then it goes back down. You can see towards the end it goes back down to flat. This patient does not snore, so a lot of people are surprised. Oh, look how bad that sleep apnea is. How bad's the snoring? This patient's not snoring. Okay, so the take-home message there is not all apneas patients snore, and not all snore patients have apnea. It's really, really important to be able to tell, because the number one thing that brings people into the dental office is snoring. Oh yeah, I snore. I see you had a sign there that says you help people with snoring. Well, I snore. Okay, it's not the whole thing, and the monitor that we have has a very good snore detection feature in it. I'm going to show you another set of data here. So we zoomed in on it a little bit more. And what we have here is a different type of, let me kind of wait for this event to come in. There we go. So we have a different type of apnea, and we have a different type of response, and there's actually also snoring. Okay, so I'll tell you what's going on here. We have a patient that their airway doesn't totally block, but it goes down, so they're still breathing a little bit, but not a lot. So that's called a hypopnea. So that's the H in AHI. So these are hypopneas. And just above those blue rectangles, you'll see these little tick marks. That's the masseter. And what this is this is the jaw kind of fit like a fish out of water, like the jaw's trying to kind of get air. Okay, so if you've ever seen somebody who has sleep apnea, sometimes you'll see their jaw kind of going. And it's almost spooky looking. This is what this looks like. And then you'll see the big giant clenches at the end of some of these events where the masseter has its full strength. So if you remember on that first patient that we were looking at earlier when we were talking today, the patient had a lot of activity, but they weren't very strong. So they had a lot of this weaker, quick stuff, but not very many of these big, strong clenches. So this patient, I would almost guarantee, has damaged teeth, because those are very, very strong clenches. Okay. A little farther below, you'll see these green lines, and I don't know if you can read it, but it says DSAT 4%. So this patient, again, these apneas and hypopneas aren't nearly as severe. So his oxygen only went down 4%. Okay. Um, and then they went back. The heart rate's a little bit high, but it stays pretty steady between 97 and 100. So this patient has less severe apnea, but the bruxism's much more severe. Okay, so totally different scenario. And when a dentist is taking on damaged teeth, they need to know kind of what's going on the lower half of the screen. They don't necessarily need to treat it, but if you're going to try to figure out what's going on the top part of this, you need to know what's going on the bottom part. And this is the problem. I should say it a different way. This is the missing data on oximetry. Okay? So imagine trying to do everything that we're doing and we have nothing but this green line. Okay? Now, the green line might be better than the green line you're looking at right now, but it's only the one channel. All right? So this is the problem. Excuse me, it's two channels because you do get the lower one too. So you get these two channels. You get the oximetry and the heart rate. So you get these two channels. You get nothing else. Okay? And from those two channels, they try to predict what's going on everything above it. Well, why not just record everything above it? Why try to guess? Why, it's simple. Just put those white belts on, put a cannula in, and you're done. Honestly, that's all there is to it. So as I'm working through the key opinion leaders that really like that oximeter, this is the type of thing that we're going to go through. And to be honest with you, I haven't been through the conversation with them, but they know enough. They've talked to Ann and Sima and Lorena, and they're intrigued with what we're doing. Okay? All right. So that's the apneas, that's hypopneas. This is how the OSA, the sleep apnea, I should say OSA stands for obstructive sleep apnea. AHI, and that's kind of the disease. And the AHI is a parameter used to diagnose whether or not you have OSA. Okay? So if you hear a physician say, oh yeah, my patient has OSA, they mean they have apnea. And then you could say, oh really, what was their AHI? And they'll say, oh, okay, you know a little bit about what you're talking about. And they'll say, oh, it was 12, not a real severe case. Oh yeah, did they Brex? Well, I don't know. How would I know that? Oh, well, let me explain to you how you could know that. So this is how kind of the conversations could go. Okay? All right, next slide. I did want to spend some time, since we just got finished talking about the sleep apnea, let's talk about the medical path. Okay? So at the beginning of our conversation, we talked about the dental path. Now we're going to talk about the medical path. So the medical path, this is a report. And step one is a physician has to diagnose the patient with sleep apnea. And this is one of the challenges that dentists have, especially the busy general practitioner. Does he really want to have to fuss with finding a physician or using us to diagnose them when all he wants to do is make guards? That's a business decision. If they say, yes, I do want to fuss, I do want to get into sleep apnea, that's two thumbs up for you guys, because that's what we do really well. If they say, no, you know what, I've looked into sleep apnea, it's just not something I want to get into. So we completely understand, we have a path for you too. Okay, and that's the dental path. That's the first report that we talked about. The report that you're looking at right now is generated by a physician having reviewed the data that the dentist collected. I say, oh yeah, it looks like you do have sleep apnea. In this case, there is no sleep apnea. The AHI, see right there in the middle of the page says AHI is 1.6. That number needs to be 5 or higher. So this patient did not have AHI. Actually, this is a compliance report, so that's why it's so low. So this patient was diagnosed, is wearing a sleep appliance, and the AHI is below 5. Bingo. We're done. Patient's been treated with sleep apnea. So this is the medical path. The medical path starts with the same way, ordering a test. And for the medical path, then once the test is done, the dentist orders the physician to diagnose the patient. In the case of the dental path, they just shoot an email to DDME and says, let me know what the next best step is. In the case of the medical path, the physician says the next best step is, and then whatever that is, in this case, the recommendation is keep using the oral appliance. It's working. Okay, so that's from a physician. There's two good reasons why physicians have to be involved in the medical path. One is sleep apnea is a medical condition. Okay, now the second reason is it's illegal for a dentist to diagnose sleep apnea. Two really, really good reasons why you want a physician involved if you're going to take on sleep apnea. And if you want to do that, we're great at it. If you don't, we're good at that too. And we'll manage both tracks depending on what your potential client wants to deal with. So again, this is a physician report. Okay, so I did want to go back. All right. At this point, I want to take another pause. Is there any questions before I move on to the BRX Pro? I'm checking chat here real quick, see if there's any there. I don't see any. Okay. All right. So now we're going to talk about, we've talked about bruxism, dental path. We've talked about sleep apnea, the medical path. They're separate. You might start with one and skip over the other. We got a lot of dentists that say, I went to a thing, I learned that I don't want to do it, but I like being able to treat bruxism. They get into it and they change their mind. That happens a lot. So don't be disheartened if you talk to somebody and says, I looked into it, it's not for me. Say, yeah, it's not for a lot of people, but the bruxism part, let's talk about that. Okay, so don't be afraid to have that conversation. Okay, so what we've learned from collecting a lot of data like this, so on your, when you see a lot of people with apnea and bruxism and there's just a lot of fussing going on, and you got a dentist who says, I really don't want to tackle sleep apnea. And we say to them, well, your patient has sleep apnea. What are you going to do if you learn that, and this is what I'm going to talk about next, single arch occlusal guards 10 out of 14 times cause apnea to get worse. Okay, so let me reiterate that. In dental school, dentists are taught, okay, if you see damaged teeth, there's a number of things we need to do. Step one is usually protect the teeth to prevent further damage. Okay, that's the first day of occlusion. Okay, so then what happens after that's completely up to the dentist. But what we were concerned about is what happens when a dentist doesn't know anything about the patient other than they looked into the mouth and it says chipped or worn teeth, and they want to start helping the patient with that, and so they make them a guard. What we found is 10 out of 14 patients, that AHI, that number that we've been talking about, that goes up. So there's something about those occlusal guards that's bad for the airway. Okay? Excuse me. So what does that mean? Well, it's not a big stretch to imagine that if you have a patient who has these bruxing events after apneas and you cause more apneas, they're going to have more bruxing events. Now, if you've put a guard in, you're protecting the teeth, but how much good have you done the patient? Okay, so their jaw's still firing, their jaw's probably firing, their masseter is probably going more than ever, and we see that in these numbers. So the bruxism becomes more frequent. It's not as strong, but it's more frequent. So then at the end of the day, what have you actually done except for protect the teeth at a tremendous expense? Okay, and the expense is you've made the sleep apnea much worse. Okay, so what dentists would say, okay, well, Jeff, geez, you're so smart for figuring that out. What do you want? What would you suggest that I do? I said, well, make them a sleep appliance. Oh, I don't do that. I'm not into making sleep appliances. I don't want to do it. I made one and it was a disaster. So what else? And we didn't have a good answer, because when you want to improve bruxism and it's related to the airway, you got to take the airway into account. It's that simple. And so we kind of went back to the drawing board, being kind of embarrassed, maybe, or sheepish or something, for not having a good answer to the problem we identified. Okay, a lot of people can identify a problem. The smart ones figure out a solution. So what we did is we came up with the VRX Pro, and it's a dual arch guard. And actually, Ann had a comment that's on the surface is negative, but actually is positive. And one of the comments was, well, this is kind of like a sleep appliance. Well, yeah, it is. But it's a BruxGuard, okay? And it's very simple to use. And the BRX Pro is made chair-side, and it has some features that I'm going to tell you about. And it's rather than tell the dentist, okay, you got to make a sleep appliance, we can now say, well, for less than $100, you can make them a BRX Pro and see how they do. Okay, that's a good answer. For a lot of people, when you have to say make a sleep appliance, that's not a good answer. For some people, that's a great answer. That's the whole point. They want to make sleep appliances. In that such case, make one. I mean, believe me, we're not against sleep appliances. In fact, that's kind of been the basis of my living for 5 years now. But we really need, the average dentist needs a solution, and this is it. So what we did with the BRX Pro is it's two arches, similar to a sleep appliance, but they're partial arches. So it's comfortable, and it allows for the molars don't come into contact with each other or the material. So they're floating. The molars float. And the reason you care about that, if you guys are familiar with the NTI, the whole point of the NTI is to prevent the molars from coming into contact with each other, because there's a nerve that kind of goes to the kind of cheekbone and then into the kind of the molar. And when those molars touch each other, that nerve, the trigeminal nerve, that's the T in NTI is trigeminal. That trigeminal nerve fires, and that event just escalates on an order of magnitude. And I'll show you something that's kind of interesting. What do you think the big difference between those little events and those bruxisms and those big ones is? The trigeminal nerve fired twice on this screen, and I bet you with no more training you could figure out where the trigeminal nerve went. Okay, so what we have here is a way to keep the trigeminal nerve from getting involved with the event. So the BRX Pro has that feature, and it allows for adjustment. So there is a hinge at the anterior component part of the BRX Pro, and I'll show you what they look like in a second. And that hinge is designed to accommodate where the patient's bite is. So, if you have a class 1, 2, or 3, or a normal bite, edge to edge, wherever you are, we want that mandible to stay in that spot where we know you can breathe, but also stay in that spot when you go to sleep. Okay? So that's why we have the hinge there. The both arches have retention, and when you go to sleep, the mandible stays in a known good spot. Okay. The BRX Pro is made chairside by a hygienist or a dentist, and if you can take an impression, you can make a BRX Pro. Okay. Very simple to make. There's a video I'm going to, at the end of today, soon, and either tonight or tomorrow, I'll send you a link to a video that shows you how to make these. And the guy in that video is me. And if I can talk and make one at the same time, it's easy to do. And I'm not being self-deprecating. I'm just saying it's that easy. It really is a simple thing to make. So we have an answer that's less than $100. And it's easy to make. It's made chairside. And the last thing is, does it work? Okay, so let's talk about that for a second. And I'm getting low on time. Okay, so I'm going to hustle through this. So we did a couple of patients, and we kind of measured these patients very closely, and they weren't sleep apnea patients. They were patients that were being treated for TMD or damaged teeth or both. Okay, patient 1 so we did 3 nights of testing. Nothing in their mouth. Whatever their guard was, in this case it was a full lower arch, and then we did a 3rd night with the BRX Pro. So the first thing that we did is 11 per hour. Remember that 19 per hour we talked about? So this patient's AHI was 11. Okay, that's still mild, but it's well into the mild. When they wore their full lower arch, it improved. It went to 7.6, but that's still sleep apnea. when they wore the BRX Pro, a side effect to wearing the BRX Pro is it normalized the airway. It's below 5. Okay? Great news. Okay? In the course of protecting the teeth, we actually made the AHI fall within normal limits. Now, you're not wearing the BRX Pro because you have a sleep apnea. You're wearing it because you need your teeth protected. But isn't it great that the airway improved like that? Okay? We saw that the oxygen desaturations. Those dramatically improved. Okay? And so it did a great job on the airway. Okay? Well, what did it do with the total energy on the masseter? Okay? So the BEI, the clenching and the grinding, by the way, that stands for Bruxism Episode Index, clenches and grinds. That's a term we made up. So it's, if you go to Google BEI, you're probably not going to find too much. But we had to call it something, and it had to be kind of like the same type of thing as AHI. So it's BEI. The Bruxism Episode Index, baseline 8 per hour, pretty high, about double what's abnormal. With the full lower arch, it went down again. And with ours, it had the best improvement, but it's still pretty high. Okay? So we didn't completely eliminate it, but, would you rather have 4.5 or 8, when you're counting? And then if you break it down, the clenches we cut the total clenches in half. That's a great outcome. And then the total energy, which is what we're looking at, the actual total energy expended went to 10% of baseline, which is great. So if you look at baseline is 20% of the total clench energy, it went up. Okay, so actually the jaw expended more energy on the full lower arch, but the teeth were protected. And then with ours, it went down the most. And the reason, our belief is the reason it went down to 10% here is there's fewer respiratory triggered events or fewer apneas and bruxisms. Okay? And this is, again, another chart indicating that the total energy, we just saw a tremendous improvement. So it does work. We're going to talk about another patient here in a second. And the co-founder of DDME, Bill Ross, has a neighbor, and they were kind of enjoying the weekend, what retired guys do when they enjoy the weekend. And the one guy said, geez, Bill, I snore a lot, and as a result, I'm having to sleep in one of our spare bedrooms. And Bill said, well, I've just developed this tool. Let's see if it helps. So we did a 2-night study with the patient. And there's 2 charts here, and what we're looking at, and this patient's complaint was snoring. His AHI was 7.5. Okay, and that's mild. It's barely mild, but it's some apnea. And he snored 22% of the time. So he had a little tiny bit of apnea and a lot of snoring, but he kind of already knew he snored. So we didn't teach him anything there. And you can kind of see on the chart the little blue hash marks. Those are snores detected by the software on that top chart. So then what we did, excuse me, on the lower chart, we can see his AHI went down to 1.8. So that's well within normal limits. So we kind of eliminated the airway issue. And we cut his snoring by 90%. So it went from 22% to 1.9%. Barely any snoring at all. This guy was he was ecstatic for 2 reasons. 1, he didn't snore anymore, and 2, it was free treatment. And so he was a very happy camper. Let me show you what it is real quick. The BRX Pro, what it's made of, and then I'll finish up with this. So there's 2 sets of trays with the BRX Pro. It's a little box, and then if you open up the box, there's 2 sets of trays. There's a set of therapy trays, which you're looking at, and then there's a set of impression trays, which are so common, I'm not even going to bother showing them to you. They're just impression trays. Okay, so you fill the impression tray with PVS material, have the patient bite into it, you trim it up, and then you take what we're calling an insert and you slide it into the therapy tray, and you pick a spot, whether you're class 1, class 2, class 3, and the instructions will tell you. And there's these slots, and there's a reversible hinge there, And depending on the class bite, the hinge is anterior, posterior, and then you pick the slot that the pin goes into. You put the inserts in the tray, and you're done. So the biggest time consumer is waiting for the PVS to set. Okay, so it's very simple to make. Here's the instructions on setting the pin. So depending on the class bite, you just say, oh, it's the pin's anterior, back slot, or what have you, posterior, front slot, whatever the case is, and then you've made your chair side version. Okay, there is and here's kind of some pictures of the inserts. You kind of pull the insert out, you trim it up, and you put it in the therapy tray, and then you can actually, if the patient really likes the BRX Pro, there's an acrylic version available. Or if they do really well, the dentist can make whatever appliance they want. Okay, but the idea that for less than $100 you could get them treated and see how they're doing right on the spot is a very cool feature. Okay, what they do after that is completely up to the dentist. They do have, again, they have the option of the BRX Pro acrylic. Not terribly creative, but it's just a BRX Pro that's made out of acrylic. So there's the order form for the acrylic version. It's exactly like any other appliance you'd order from a dental lab. I was going to talk about competitors today. I am not. We're going to talk about competitors on our third session. I went a little long today, but it's maybe a good idea. It might fit better with what our third session is going to be, which is essentially we're going to kind of rehearse some conversations, role playing, if you will. And we're going to just kind of have a two-way communication about how you initiate the conversation, and then some sample. I've had this conversation so many times. I'll be the dentist and you guys will approach me, and then I'll say, okay, and I'll try to throw you some curves, and then we'll talk about objection handling and things of that nature. And then we'll also talk about the ROI and competitors. So we'll have a much more sales focused conversation on our third session. So having said all that, I'm finished for today. So if there's anybody that looks like Jason has two questions, so I'll shut up and let Jason ask us. Oh, yeah, right. So there's two questions: is how long does the BRX Pro chair side? It's with the FDA, we've applied for 30 days. And then after 30 days, if it's still working and the patient likes it, you can transition to a long-term appliance. So that's the first part of the question. The second part regarding super eruption, the fact that you don't wear it during the day, and during the day is, you just do what you would normally do. There's a lot of partial arch appliances out there, and as long as you don't wear it 24 hours a day, the risk of super eruption is almost zero. Um, and that's true with any type of partial arch appliance. Some folks, what they'll do in the morning is they'll say chew a stick of gum to make sure that you engage all the teeth, and make sure that we don't start losing some ground and the teeth start erupting. But it is the key factor is you do not wear this during the day. We haven't seen it, but it is one of the things you want to look for. So with any time you put there's 5 or 6 classes of appliances. One of the classes is you don't put anything where the tongue goes, because they want to address the issue that Jason brought up. is their tongue wants to go forward, and if it can't, it's going to push the back of the tongue backwards. So in some patients, that is a problem. Okay, in in most it's not, but in some it is. So the consideration and what I tell dentists to think about is do a test wearing the appliance. You don't have to, there's zero guesswork with the BRX Pro if you measure and see how they're doing. And that's true with any appliance. So with tongue, if you happen to have a tongue thruster and the nature of their airway problem is worsens because the back of the tongue gets pushed back a little bit, when you do your follow-up test, they're going to be essentially what we call a non-responder. Okay? And then you learn that for $90 and think about how valuable that is, because that is not bad news. That's good news, because if you're going to make a long-term appliance, you're going to pick the class of appliance that doesn't have anything where the tongue goes. Okay? So at the end of the day, what Jason said is a risk. It's a risk with anything that you put in the mouth. In fact, it's probably one of the reasons why some of the patients get worse in a single arch guard. Okay? But you don't have to guess. Just do a test and you'll know. Okay? Good questions, by the way. Those are questions we get a lot. Let's see, did I miss any other chat questions? No. Any other questions in the audio? Okay. Well, I thank you very much for attending. I hope this was helpful. I invite each and every one of you to call and just pick my brain if you think that'll help you to be successful. At the end of the day, I think the primary task is to get interest, and we're going to be developing some marketing materials to help you with that. And then your goal will be to get somebody onto a 30-minute kind of web demo. And I think you'll probably learn more on those web demos with your potential client than anything else, because we do, depending on the nature of the dentist, some dentists will only want to talk about medical billing and only want to talk about OSA. Other dentists will want to spend the whole time learning about appliances. Other dentists will have other topics. So wherever it goes, we'll go there. And I think that that'll be an excellent learning experience for each and every one of you. And for me, my deliverable to you will be to make sure that you have a copy of what we just went over. I'm going to send a link of both this presentation and the previous first session presentation. And look for that in a day or two, okay? So with that being said, we're going to close it out, and I want everybody to have a great day, okay? All right, thanks, guys.